Before I get into each of these different areas, what I want to do is I also want to touch on how disease patterns have changed over the last century, and what are some of the challenges in terms of disease states of today that the drug industry is faced with, and where we see the next 20 or 30 years as to how disease patterns would change. If you look at the disease states over the ever since 1990s, globally we've faced huge challenges to treat infectious diseases, mostly diseases caused by bacteria, fungi, parasites, and that by far was the largest killer in terms of diseases. So infectious diseases, if you see diseases such as pneumonia, tuberculosis, were some of the prime killers in the past. Today, given the way drug therapy has gone, we've pretty much eradicated, or we've been able to effectively treat most of these infectious diseases. And the challenge for the drug industry today is mainly in the areas of chronic diseases. Chronic diseases are diseases where progression is slow, and clearly by far the maximum number of fatalities in today's environment comes from chronic diseases such as heart attacks, cancer, various respiratory diseases. Chronic diseases are primarily predominant because of the lifestyles that we all lead in today's world, in terms of high stress level, diet being a major issue for most of us. And these are the main reasons why chronic diseases are pretty prevalent in today's environment. The future of disease states, we believe, will shift from chronic diseases to more degenerative diseases. Degenerative diseases being where there is a progressive deterioration of some of the tissues of the human body. And these are diseases such as Alzheimer's, various types of cancers, Parkinson's. That's pretty much where the disease pattern will shift to in the next 20 or 30 years. And it's important to recognize this because the drug industry is clearly aligned with the progression of some of these diseases. If you go back as to how the drug industry has evolved, and you look at small molecules were primarily designed in the early days to target mainly the infectious diseases. It all started with serendipity, with the invention of penicillins, which purely was discovered accidentally, to over the last century has evolved to more a targeted approach, and until recently you're seeing drugs designed by what you call as a rational drug design. There are various factors which have contributed to this transformation, and I'm not going to spend a lot of time on it, except to say that clearly instrumentation, biochemistry, general biology, as well as technology in terms of combinatorial chemistry, computational drug design has played a significant role to get here in terms of small molecules, in terms of moving from serendipity to coming up with molecules which are more focused and more current in the environment. Also, the FDA, the US FDA, the changing guidelines have played significant role in terms of drug development and how new drugs have evolved. Over the last 15 years, you've seen a large rush of new drugs, and clearly some of the blockbusters in terms of new drugs have come in the last 15 years. Classic examples are drugs such as Lipitor, Prozac. They were all outputs of rational drug design and chemical-based approaches that were taken by the drug industry. Clearly, one of the significant trends we are seeing is there's a rapid decline in terms of opportunities in the small molecule area, primarily because of some of the disadvantages that one sees with small molecules. Even today, you have over 2 million people who experience adverse drug reactions because of small molecules, and over 100,000 fatalities every year that you're seeing because of some of the adverse reactions of these small molecules. Also, often small molecules do not reach the site of action because most of them are metabolized by the liver. They never really reach the site of action. Additionally, most of the gold standard molecules today have pretty much left little scope for improvement with the kind of work that's been done in chemistry over the last decade. In addition to this, there are certain new trends which we are seeing in the pharmaceutical industry, which is clearly paving the way for new therapy. The Human Genome Project, I know someone talked about it earlier today. Clearly the Human Genome Project, where there's over 10 years of work which has gone into trying to define the DNA of a human being, trying to isolate every single part of the human being and identifying each and every DNA and trying to understand the sequences of these DNAs. So that's clearly paving the way for new drug treatment and new targets. Also a better understanding of the overall human immune system and immunology is helping shift trends. The FDA playing a significant role because today the FDA looks at a risk-benefit analysis. So if you're number 6 or number 7 in line for approval, you better be able to show a beneficial effect either by way of safety or by way of efficacy to the agency in order to get approved. And that's clearly shifting trends. So what you're seeing is most of the global pharma companies, if you take the majors, Merck, who acquired Serono, AstraZeneca acquired MedImmune. So there's a large amount of M&A activity going on primarily to get into move away from small molecules and to get into biologics, which is the new emerging trend in the industry. And there's a rapid rush of most of the global pharmaceutical industry trying to move away from small molecules to get into biologics and newer therapy. If you look at biologics, what exactly is a biological drug? A biological drug is nothing but it's a substance which is made from a living organism or its products, and is primarily used for prevention, diagnosis, and treatment of various diseases. Biologics, the 4 main categories, and I'm not going to spend too much of time on all the categories, but the 4 main categories are insulins, vaccines, antibodies, and therapeutic proteins, of which the antibody space is the most promising space in terms of the future. The benefits of biologics over some of the chemically synthesized molecules is clearly pinpoint selectivity and much more specific. It also has much less toxicity because since these are substances which are easily recognized by the body and are produced by the body, they're much less toxic as compared to small molecules. Also, they have a much larger and longer effective patent life purely because of the manufacturing challenges that exist. So I guess most of big pharma and most of the global environment is moving towards biologics, towards antibodies and biologics. Within biologics, clearly antibodies is the most exciting area. And if you look at antibodies, what are antibodies? They're basically when the body is under attack from either a bacteria or a virus, also called as antigen, the body secretes antibodies to fight these infections and clearly help destroy them. So this is something which the body synthesizes as a natural process. What drug companies are doing is they are now taking this and artificially synthesizing antibodies and injecting into human beings to bolster or to enhance the defense mechanism of the human body. And that's pretty much what most drug companies are doing. Also, antibodies have some very unique characteristics. One of them is, when in some antibodies, when they're activated by the occurrence of a disease, they continue to confer resistance against the disease. A classic example is those of you who've ever suffered from chicken pox or smallpox. clearly recognized that the likelihood of getting that again is very low. It's purely because those antibodies have been activated by the disease, and the body is now recognizes that and is able to fight subsequent attacks of these diseases. In terms of antibodies, if you see the evolution, it started with a mouse antibody where a certain antigen was taken, it was injected into a mouse, and the mouse produced antibodies. Those antibodies were taken out of the mouse and then grown on a particular cell line and then given to humans, and in order to bolster the human immune system. Clearly, one of the biggest side effects there was the whole immunogenicity being the biggest challenge for that came out of the mouse antibody. Subsequently, things have moved on from the mouse antibody to making a humanized antibody, where a certain fragment of the mouse antibody that was withdrawn from the mouse was replaced by a human fraction called as chimeric antibodies, and then injected into humans. And then today, the recent trend is to go to a fully human antibody, which is clearly DNA genetically engineered and completely novel. Advantages of antibodies, clearly better safety because they are recognized easily by the body, and they're not viewed as a foreign object. Also, they have a better ability to reach the site of action because they're specifically designed to reach the site of actions. Excellent in disease states such as cancer and rheumatoid arthritis, where antibodies are widely used in the Western world. They're very complex in terms of the manufacturing process, and the threat of generic competition is minimal because the manufacturing processes are pretty complex. Some of the challenges facing antibodies, most of the antibodies are injectable, so clearly with the future being in antibodies, most of us need to get used to taking a lot more injections. However, there is significant amount of efforts currently being made to try and use other delivery mechanisms. You had Exubera, which was an inhaled insulin device. And now, people are trying to use inhaled technology and various technology to administer these antibodies through a different delivery mechanism as opposed to the injection. Also, most biological manufacturing is extremely complex, and therefore it's a huge challenge for most generic companies to come up with biologics. And hence, biologics are clearly the way to go in terms of, we believe they will dominate the space at least for the next 15 or 20 years. If you look further out and say, what are some of the technologies that global companies are working on which seem exciting? Regenerative medicine is clearly a new exciting technology, primarily being stem cell research, which is predominantly being worked on by most of the world, and the next technology is personalized medicine, and I'll just quickly touch on these two subjects. Stem cell research a stem cell is like a magic cell, basically. It has the ability to self-replicate for indefinite periods of time. At the same time, stem cells can actually modify itself, change its shape, characteristics, and function to adapt to any cell of the body, such as heart cells, skin cells, nerve cells. They can pretty much replace or take the place of any one of these cells. So it's a very, very exciting technology from a regenerative standpoint. There are three promising types of stem cells. You've got embryonic stem cells. Embryonic stem cells are derived from the human embryo. So during in vitro fertilization, for the most part, the embryo which does not get fertilized is used often as a source of stem cells. You've got hematopoietic stem cells and you've got cord blood stem cells. If you look at the embryonic stem cell, clearly is the richest source of stem cells and is very exciting from a standpoint of cell replacement. So if you, in a degenerative condition where your body is, or you've got Alzheimer's or Parkinson's, the likelihood of these cells, these stem cells being injected and taking over or replenishing some of the degenerated cells is extremely high, and that's an extremely promising area of research today. The other use is in the areas of exploring new disease mechanisms and drug discovery also, in terms of screening of new compounds and chemicals in terms of embryonic stem cells. If you look at hematopoietic stem cells, these are basically blood cells which pretty much come from the bone marrow. However, it's an invasive procedure, so there are other ways of getting hematopoietic stem cells, and these are blood cells that can actually form platelets, neutrophils, and RBCs and various other cell types and cell components, and could be very useful in cases like blood cancer and various other diseases where hematopoietic stem cells could actually replace some of the degenerated cells. Cord blood stem cells is the third type, which is basically got from the umbilical cord. So when you've got a newborn baby, and the umbilical cord is generally stored, and that's a recent trend, with the view that tomorrow you could use that as a rich source of blood supply, or as a rich source of cells of stem cells that could take over and be used more aggressively in terms of replacement of human blood. So it's especially relevant where families have a history of illness, and these could be used, and blood disorders, these could be used more aggressively in some of the blood disorders. Stem cell transplantations, there are two types of transplantations. You've got an autologous procedure, and this is a pretty significant threat for most of the industry, because if the autologous procedure actually works, then a person would receive his or her own stem cells in transplantation. And then you've got an allogenic procedure where a stem cell from any individual could be injected in some other individual, pretty much an anonymous donor, in which case it could be commercialized and mass production is possible. But in case of autologous, you can be given your own stem cells. So it's limited to in terms of manufacturing and growth. Personalized medicine is the last is the second area that I'd like to talk about in terms of the role of personalized medicine. Personalized medicine is nothing but it's gene variations. So each one of us have got a different genetic code, and that's the reason we respond differently through drug treatment. So drugs given to one individual will respond very differently as compared to another individual. The idea is to understand this genetic variation a little bit better, and if we're able to do that, then we can actually come up with medication which could be used, which could be very specific for a particular individual with a particular genetic code, and it would help physicians treat patients a lot better and with much more specific influence on most of the patients. Some of the advantages of personalized medicines, very targeted towards certain sets of people. Adverse reactions are minimal. The trials are much smaller. The challenges is every human being has over 30,000 genes, and the understanding is currently very limited. However, it will begin to get a lot better. And also diagnostics will play a major role in terms of understanding personalized medicine and being able to diagnose some of these genetic differences. Funding is clearly limited. Long-term efficacy studies have yet to be conducted for personalized medicine. So there are quite a few challenges in terms of moving forward with personalized medicine. But over the next couple of decades, clearly there will be a move towards personalized medicine. So where does India stand in this entire game of innovation which is going on globally? Clearly, India's quest for innovation has been less than 15 years. So it's only 15 years that India is truly doing pure innovation compared to the West, which has been working in innovation in the pharmaceutical industry for over 100 years. India traditionally had the perception of copycats and copycats of drugs and reverse engineers. However, I think over the last 15 years, there are a host of Indian companies who have actually taken steps in the direction to build innovation as their backbone, and clearly Glenmark is on the forefront there in terms of innovation. Resources for innovation in India are extremely limited. The top 5 companies in India have 1/40th the R&D budget of a Pfizer. Also, limited access to external funding, venture capital funding, government funding is limited to fuel innovation. Academia, government labs, unlike the West, I think most of the government labs and academia are yet to make an impact in terms of innovation. A lot of innovation in the West comes out of government labs, and in India, it's still a challenging environment. Today, most of India is still focused on small molecules for a variety of reasons. First of all, the talent pool as far as chemistry skills go in India is exceptional. India has a very large chemistry talent pool, and clearly which is world-class. And companies such as Glenmark, we've used that talent pool very effectively, being the leaders in the space, having done 4 deals with Lilly, Merck, Forest, Agen, over $800 million in milestones. Most of those deals and most of those molecules have come out of chemistry-based approaches, which we've used in India very effectively. Also, there's a very low cost of setting up the infrastructure for development of small molecules. Biologics is an area where India is currently struggling. We really don't have the requisite skills to work in the novel biologic area, and that's one area, given the trend that the global environment is moving to, it's extremely important that India starts building these biologics skill sets and starts working in the area of both biologics as well as stem cell research to catch on the next wave of innovation in the global environment. Clearly, the belief is that if India has to become a global player, it's in the field of pharmaceutical innovation. There has to be a very, very succinct effort from both the government and the industry, and chalk out a clear strategy as to how to transform this industry to capitalize on the future, mainly being in the biologics as well as stem cell research. This is a skill set that India currently doesn't have, which we clearly need to try and adapt. At Glenmark, we've over the last 4 years, we've been conducting research in biologics in our Swiss entity because of the lack of skill sets, and we're trying to bridge some of those gaps that India currently has. But clearly, as a country, India has a lot to offer, and if we could nurture those skill sets, it would be useful for the entire industry as a whole. So that's pretty much what I had. I tried to keep it as succinct as possible. I know it's a very heavy subject to be talking about at 6 o'clock in the evening, so thank you very much. Yeah.
Thank you, Glenn, and thank you again, Stephen. We'll now open it up for Q&A, so if you could please raise your hand and we can have the mics passed around. And let's start over here, this lady. If you could please introduce yourself and address your question to a particular specific person, that would be great.
Good evening. My name is Kate Elfrink. I have a question for Mr. Attenborough. I watched your movie, and of course, there's no denying this is all extremely intriguing. But the question I have is, how do your passengers get back in their chairs the minute they go from zero gravity back into gravity? Do they then fall out of space or lie on the bottom? That wasn't in the movie, and I find it extremely intriguing.
I don't think anybody's asked me that question before, but it's but it is a good question. And you know, you're obviously going to be heading to the right part of the spacecraft, as you rightly point out, because as gravity comes back in, you're going to be sort of down on the floor. The interior of the spacecraft actually is something that we're developing, and we're developing several versions of it at the moment. The version you saw on the animation, I think probably won't be what we end up with. I think what's likely to be the case is that we will aim to have a cabin floor, which is possibly made out of the I can't remember what it's called, the tempura foam, which so all you will need to do is just to get back onto the floor. And the seats that we have on the way up that will sort of hold you as you're going up to altitude, and then on the rocket burn up to space will be seats which will fold away. And so you will only use them in that time on the way up, and then possibly on the glide down as well. You actually have, I think, about 23 seconds between zero gravity and 1G. So it is a reasonable amount of time actually to get people, in the right positions. But we have debated this at some length internally, because the G's on the way down are quite high, and it's important that you are lying down, so the G's are coming from front to back rather than head to toe. And it's important that if you're lying in a seat, that you're in the seat properly, because you go up to about 6 Gs just briefly. So actually just having people lying on a soft floor is probably the safest way to do that.
Thank you. Back over there.
Is the rocket itself a single rocket or dual rocket?
It's a single rocket. It's a hybrid rocket motor.
So when you're coming back, are you using the rocket to get back?
No. As soon as you turn the rocket motor off at the end of the boost on the way up, that's the last time you use any power. Gravity brings you down, and as I said, the rate of descent is slowed by those rotated wings, by the feathers. When you rotate the wings back to the aircraft configuration, you've got a carbon fiber glider and a nice half an hour or so of a glide back down on an unpowered landing.
Thank you. Gentleman over there, yes.
During re-entry, there's so much of resistance from the atmosphere that the heat temperature goes up very high. In the absence of heat shields, don't you have any special treatment on the outer skin of the aircraft?
Well, that's another good question. You'll see if you come and look at the model, there is some very limited thermal protection that is required for this, but there is no special heat shield that is needed. And there are two reasons for this. The first, remember that we're not going into orbit with this spacecraft. So we're coming back into the Earth's atmosphere at roughly the same speed that we went out of it. So we're coming in at about sort of Mach 3.8 maximum. So that's it's fast, but it's quite a lot slower than you'd come back if you were coming in from orbit. But the main reason that we don't need this thermal protection is because the aerodynamic design and the rotated wings, the feathering effect, actually slows the spacecraft in the upper atmosphere to an extent where you never build up excessive heat. So the carbon fiber construction, with the exception of a couple of specific areas, is robust enough to withstand the heat that is built up in that feathered re-entry. And that was something which was just a masterpiece of design, and something which really transformed the levels of safety in what, as you rightly say, is otherwise quite a dangerous point of spaceflight.
Stephen, as you can tell, this is a very knowledgeable audience who's going to ask you a lot of questions before they take this up in front. Yeah.
I want to ask Glenn a question.
Sure.
Glenn, you spoke about stem cell research. Now, there have been ethical issues about stem cell research in the United States, where people debate that life starts at conception rather than at birth, and if you're using embryonic stem cells, you are violating life. I don't know if the Indian government has a stand on that position on stem cell research, but why is there so much controversy over here on stem cell research, and what can you do to convince people that stem cell research is good?
Well, I guess, since you're using, you're using live embryos, right, as a source of stem cell. There's always going to be the ethical issue, especially with certain conservative governments, right, in terms of stem cells. I think recently there's been a rampant move towards, there's a lot more acceptance of late in terms of patenting of stem cells and patenting of especially embryonic stem cells as compared to the past. I know in India there are a couple of institutions who have some ongoing efforts in embryonic stem cells. It's still very early days, but some of the work which has been done is extremely exciting in terms of embryonic stem cells. So there is clearly an ethical issue, depends on which way you look at it. If you're ending up saving life, right, and if you're actually able to treat degenerative diseases, right, through stem cells, there is a huge argument for allowing embryonic stem cells to be used going forward.
Over here in front here.
Thank you. My name is Rachna. Thank you very much for the presentations this afternoon. Questions for you, Glenn. The first question is that previously there was a well-recognized arms race. Now there's a recognized drug race, and the need to be first to market and have the best profile in terms of efficacy and safety is paramount to a drug's commercial success. So how do you deal or how do you manage with your development program so that you have the best drug profile? And then I have a second question after that.
Sure. So I think, what we did was at Glenmark, our approach was a little different, right? In the early days, when we did chemical-based research, right, chemistry-based, all our focus was on shortcomings of the three drugs in the clinic that were ahead of us. We were able to identify certain shortcomings and use that as a platform for research. So we did that very successfully, and that's the reason we were able to conclude deals with Merck, Lilly, Forest, and Teijin, all four majors. I think today, obviously, it's a much more challenging environment. But some of the new targets that are coming up, right, with the Human Genome Project in particular, I mean, there are numerous amounts of new drug targets which are out there. If someone has to actually take them up and conceptually identify and work on them, right, there's a clear opportunity to be first in class. Also, some of the biologic work that we're doing out of Switzerland, I mean, we're completely working on the two targets we're working on where we are clearly first in class. They're completely novel, and from there on it's a race, right, as to who gets there first. But you clearly have a head start in that space.
Thank you. And the second question actually is on biologics. And one of the key issues with developing biologics is the R&D expense. And obviously it's very expensive to develop a drug commercially. I think it's estimated that a small molecule costs nearly $1 billion to get a blockbuster. So for a biologic, it will cost obviously a lot more. But the issue is really how does that translate to patients, and how do they pay for the cost of biologic treatment, and how do you see that progressing going forwards?
So I think the strike rate for biologics is far, far better than small molecules, and that's the reason to be doing that. Purely because, by virtue of being a biologic, the human body, since it's something which is generated by the body, it's less likely to reject in terms of toxicity and profile, right? It doesn't go to the liver to get metabolized like a typical chemical entity. So it goes straight into the bloodstream, and it's very well accepted by the human body. So the strike rate is much higher in terms of druggable candidates, right, in the biologic space. I guess in terms of cost of therapy, clearly cost of therapy is high, and you will see the cost of therapy staying high purely because of the manufacturing challenges. So it's a huge challenge to make sufficient large quantities of biologics, and that's a huge challenge globally that most companies are facing in terms of the manufacturing challenges. So that's the reason cost of therapy is high. But also, I mean, if you see biologics today, I mean, you could take one injection a month, right? And so it's, because of the long half-life, some of these biological entities, you may need one shot a day, right up to one shot a year, right, and you'd be fine. So there are significant advantages where you just take one shot a month or one shot a year, right, and you could be okay in some disease conditions.
But even then, I understand, for example, for Avastin, it costs $50,000 for 10 months supply, which is the average cost of therapy. So the costs are remarkably high for many patients. So
Sure. I think it's a huge challenge, but the efficacy is far, far better than what you could get. So I think it all boils down to survival rates and those aspects, right? If you're able, in a case, in a cancer patient, if you're able to extend out life for a couple of years, it's pretty significant, right? And that class of patients don't mind the incremental cost. So it's a fine line, but clearly the biological therapy is here to stay in the long run.
Thank you, Glenn. Gentleman standing over there, yep.
Glenn, I'm Ken Onsraj from New York. I have a question on regulation and how do you essentially self-regulate with international standards?
Are you referring to at Glenmark or?
At Glenmark, yeah.
I mean, I think today the game is completely global, right? I mean, if your end game is to license to a big pharma company, clearly you would have the systems, procedures, the quality checks and the standards, right, to meet that. So before licensing a molecule, right, a big pharma will go through an extensive due diligence exercise, right, for which they're paying you the large upfront payment. So there's a lot of systems and procedures that one has already built in place and is constantly building as you go forward.
Here, over in the front.
Does that answer your question, or? Well, so everything that we do, I mean, so our guiding principles are all as per the FDA. I mean, for a Glenmark per se, right, we file INDs with the FDA, so right in the early stages, right, we start communicating with the agency very early in the process, pretty much like any other company globally, especially in the US or coming out of Europe. So it's pretty much a global game. Today everybody wants to get to the agency as early as possible to get as much information early in the development process, right, so that you don't put up a lot of capital and then realize you've got a problem. So I think the game is completely global today. You'd get in FDA's comments, you'd get in the thoughts of the agency very early in the process, and then accordingly you'll develop your clinical plan to meet those requirements.
Okay, we have time for 2 more questions, please.
Thanks. A question for Mr. Attenborough. Ajay from Cisco. When I heard that you said 5 minutes of excitement in the space, can it be more than that?
You get a lot more than 5 minutes excitement, but you get the actual time in weightlessness on this flight is about 4 or 5 minutes, and that's determined by the height or the altitude that we fly to, which in turn is determined by the amount of power that's required by the spaceship. And there's a very fine line actually between the amount of time that we give for weightlessness and the g-forces that are involved in the acceleration and the deceleration. So the more weightlessness you get, the higher you've got to go, the faster you've got to go up, and the faster you've got to come down. We think that line is about right, because we've tested our first 100 customers. We've put them all in a centrifuge. It never been done before. Very wide range of medical histories and conditions, and it looks like the vast majority of people are going to be fine with this flight at that G-force level. If you put the G-forces much higher, then you might have a problem, and the market effectively gets smaller. So I think I always equate it a little bit to Everest. I mean, people spend a similar amount of money preparing and going and climbing Everest. Nobody really ever asks how long you spend on the summit. It's the fact that you've got there and that you've experienced something that very few people have experienced, and the memories obviously last a lifetime. I think the other thing is that you have to remember that this is a first step. I mean, what we're trying to do here is to demonstrate safety and commercial viability of spaceflight for ordinary people. If we can do that, we expect there to be a wall of private sector money which comes into the industry because it suddenly looks attractive. And then you could see things develop really quite quickly, so we could extend to orbital spacecraft which have similar levels of safety and inclusivity as this craft. And then the idea of space hotels and a fortnight in space become a real reality. But we have to get this, we have to get this right first. So a step at a time.
Thank you. Last question from the gentleman back here.
My question is to Mr. Attenborough. A little technical here. You said this aircraft is going to be one of the largest aircrafts produced.
The largest carbon composite aircraft, yeah.
Okay, and since it is carbon content, could you just throw some light on what would be the all-up weight with the total configuration?
I couldn't, I'm afraid. It's something that we haven't disclosed publicly as yet. There's a lot of commercial confidentiality in this program still, because what is being developed is very valuable IP. So there's certain things we're prepared to talk about, like the wingspan and the cabin volume and that sort of thing. The weight we haven't disclosed yet, I'm afraid. But what I can say is actually that it has that aircraft will carry about 25% more weight than is represented by a fully crewed Spaceship Two. So we have over-engineered it specifically because we think that the aircraft itself has a lot of other applications which will require it to lift slightly heavier weights to high altitude.
In relation to the safety,
yeah.
Okay, you don't give the figure of all-up weight or the max takeoff speed, but a simple brand question: what kind of tire are you going to use on the aircraft?
What kind of tire?
Yeah. What brand of tire?
What brand of tire?
Yes.
Yeah. That's another question I've never been asked before.
Virgin tires?
Virgin tires, yes. A new business. You might have seen on Spaceship One actually that when it lands, it has a skid on the front rather than tires, and that's going to be the same for Spaceship Two as well. So there'll be normal undercarriage under the wings and then a skid on the nose. But yeah, definitely Virgin tires.
Still a lot of hands up, so I'm going to take one more, please.
Toby Burton from Francisco. Question for Glenn. Glenn, for somebody born today who has a healthy diet, who does a lot of exercise, maybe a couple of Virgin Galactica space flights during their lifetime, what is their life expectancy going to be if they could access all of your portfolio of regenerative and biologic drugs?
Sorry, just say...
What is their life expectancy going to be if they could access the full portfolio of your drugs?
Well, I guess, are you referring to Glenmark per se, or are you referring to my presentation, right? If you've got stem cell research, right, and if stem cell research actually has to work, right, you could expect a pretty significant increase in the life expectancy, right? I think there are a lot of challenges that still have to be answered as far as stem cell research goes. But clearly the concept and the technology, right, some of the initial papers and findings, right, shows a lot of promise in terms of especially embryonic stem cells, right, and their ability to transform into various cell types. You would see significant increases in life expectancy.
I've pleaded for some more time. Back over there, please.
I'm Chandra Uday Singh. I have a question for Glenn Saldanha. I think one of the very important new drug discoveries that's been reported in the last few days is that placebos work better than all your discoveries. Is that correct? And the follow-up question is, apparently the more expensive the placebo, the better it works. Now, isn't it better for you to just research salines and how to deliver them?
I think you're asking the wrong guy, right? I'll be out of business if I have to answer that. Clearly you have to. I think drug treatment actually works very clearly. You've got some pretty serious diseases out there, right, which are being treated, and you're seeing clear improvement in survival rates. Cancer is a classic example. Ever since the whole biological entities have been invented, you're seeing significant increase in survival rates of patients. AIDS is another classic example. Today, with AIDS treatments, you've been able to extend life over tens of years, compared to, initially what it was. So drug treatment clearly works. There's no... Sorry? Clearly, there are millions of reports that come out every day on healthcare and on medications, right? Even in India, there's a bunch of newspapers who keep publishing articles on new innovations, and some of them clearly I don't think are accurate at all. Thanks.
Thank you. I don't have any credibility left, but this is truly the last question.
Hi, my name is Priyanka. This last question is Mr. Attenborough. In your most inspiring presentations, you've promised us the space. When do you get us the moon? And on a more serious note, once you're up there in the sky, what do you exactly see? Is it just one part of the Earth, or is it the entire...
Okay. Well, let me answer the second question first, because that's easier. And that is that you don't see the whole globe at that altitude, but you see about 1,000 miles in any direction. I should have looked up actually before I came what that would mean if you were to fly from Delhi, and I'm not sure what it does. But it's the views that you saw, from both films actually were in the animation we used the views that we took from Spaceship One. And it's pretty much the same view, a little lower, but pretty much the same sort of view that the astronauts from the space station get, as they orbit the Earth. And I think the impressive thing is, from all accounts, that you're sitting in the blackness of space. It's broad daylight, but it's still black. To look back and particularly see the thin layer of atmosphere around the Earth. And the reasonable view of the continents and oceans from wherever you're flying from, is by all accounts a pretty dramatic experience. Richard Branson's talked about getting to the moon, and we don't have any specific plans on that at the moment. But I think that the general point is, as I said before, that space access needs to be transformed in so many ways. We think we have a system here that transforms it extremely well, certainly for suborbital flight. If we do this right, if we keep people safe, if we make money as a commercial venture from it, then I think you'll see or potentially see really rapid developments. I'd love to go to the moon, and I'm sure a lot of other people would as well. So let's keep our fingers crossed.
Thank you, Glenn. Thank you, Stephen. Thank you, ladies and gentlemen. We truly live in interesting times. Let's make the most of it. Thank you very much.
Mr. Puri, if I could request you to please come up and present our speakers. Mr. Puri, if I could request you to please come up.
You're not accustomed to this.